ನಾವೇನು ಮಾಡಲ್ಲ.
ಅಲ್ಲಲ್ಲ, ನಾವು ಅಂದ್ರೆ ಊರ್ಗ್ ಹೋಗ್ತಿವಿ. They do that for ancestors ಗೆ ಪೂಜೆ ಮಾಡ್ತಾರಲ್ಲ. They do that. ಪಿತೃಪಕ್ಷ. They do.
ಎಲ್ಲ ಇದೆ. ಉಡುಪಿ ಮಣಿಪಾಲದಲ್ಲಿ ಸ್ವಲ್ಪ ಜಾಸ್ತಿನೇ ಇದೆ.
ಹೌದಾ?
But I somehow don't observe anything.
Okay.
Atara.
I think most doctors are like that.
Yeah. Alla, we are doing
service otherwise.
To be done.
Service otherwise. That's what.
ಈಗ ಇದ್ದವರಿಗೆ ನಾವು ಸರಿಯಾಗಿ ನೋಡ್ಕೊಂಡ್ರೆ
service to God. That is better to the human beings ಮಾಡಬೇಕು.
ಇದ್ದವರಿಗೆ ಸರಿಯಾಗಿ ನೋಡ್ಕೊಂಡ್ರೆ ಸಾಕು. ಓದೋರು ಏನ್ ಮಾಡಕ್ಕಾಗಲ್ಲ.
My grandmother used to always say that. ಇರುವಾಗ ನೋಡ್ಕೋಬೇಡಿ, ಸತ್ತಾಗ ಎಲ್ಲ ತನ್ನ ಸಮಾಧಿ ಮೇಲೆ ಹಾಕಿ ಏನ್ ಮಾಡಕ್ಕೆ ಅಂತ she used to say.
Exactly. Those are the correct words.
She used to always say that.
That's what I believe in. When people are alive, you just do whatever you want to do.
ಮತ್ತೆ ಮಗಳು ಬರ್ತಾ ಇದ್ದಾಳೆ ಈಗ.
ಅದೇ ನವೆಂಬರ್ ಅಲ್ಲಿ ಬರ್ತಾಳೆ. There is a wedding in their family. Brother-in-law is getting married.
ಸರಿ.
So then she is coming, so we are also coming.
Good.
And from there, all of us after the wedding go to Manipal, because she has also not
3 years ಆಯ್ತಾ?
3 years ಆಯ್ತು Manipal.
3 years ಆಯ್ತು ಪಾಪ. ಕರೆಕ್ಟ್. they'll miss. ತುಂಬಾನೇ ಬೇಜಾರಾಗಿರುತ್ತೆ. ನನ್ನ ಮೊಮ್ಮಗಳು ಹೇಳ್ತಾಳಲ್ಲ, ನನ್ನ ಮೊಮ್ಮಗಳನ್ನ let us go somewhere in the no, I want to come to India. She only wants to come to India. ಪಾಪ 2 ವರ್ಷ ಆಯ್ತು ಬಂದವಳು. She wants to come to visit all of us in India.
Yeah. So it is 7:27.
We'll start in another 2 minutes. Parag, I think, has joined.
Yeah. Is there any other live streaming? Because I can see only 7 people here.
I know, that's what I also was going to ask him just now. Arun? I didn't see Arun also here.
Yes, sir.
We are seeing only 7 people here. Do you mean to say it is others are in the live stream? Other audience?
Sorry, sir, I can't understand.
Is there another participants link?
Is it a separate link for participants?
Arun? Yes, sir.
How many are there now in the webinar?
We are seeing only 7 people here.
Yes, sir.
To say it is
7 only, sir.
in the live stream?
No. Only 1 link, sir.
Only 1 link. Then where are the invitees? Another participants link?
Is it a separate link for participants?
No. It's 1 link, ma'am.
Nobody has logged in this way.
7, sir.
We are seeing only 7 people here.
Yes, sir. Yes, sir. 7, sir.
In the live stream?
No.
Who is speaking? I can't hear the voice clearly of the speaker.
Now, sir.
Yeah, now okay.
Hello. Okay,
Yeah.
sir. Okay. Only 7, sir. Single link, sir.
Okay.
I'm waiting, sir. That's all. Shall we wait another 5 minutes, sir? It's 7:28.
No, we will wait for the 3 minutes.
Okay, sir. Done, sir.
The triangle, I mean square. Okay, well.
Dr. Durga Das, namaste. Mute ಆಗಿದ್ದೀರಾ? You're muted.
ನೋಡಿದೆ, ಬಹಳ ಸಂತೋಷ ಆಯ್ತು.
ಹೌದಾ? ಸ್ವಲ್ಪ I need all your support. ಎಲ್ಲರೂ ಹೇಳ್ಬೇಕು ನೀವು ಎಲ್ರಿಗೂ.
ನಮ್ಗೆ ಗೊತ್ತಿದ್ದವ್ರು ಖಂಡಿತ ಹೇಳ್ತೇವೆ. ಡೆಫಿನೆಟ್ಲಿ. Outside
state, Dr. Parag. I am going to put my nomination for the medical disorders in pregnancy committee.
Oh,
I need your
great.
support.
Sure.
I need your
all the
support.
best.
Please tell all your voting people, ICOG, and all your.
Sure. But
uh,
you need to
friends.
promote yourself aggressively.
Yeah, that's
The
what I've
election
started doing.
is still 6 months away, but
Yeah,
then you
still
need
6
to
months. Yeah, it's
be
still
very
6 months.
aggressive.
Yeah. So I need your
Because
guidance.
that is the current trend.
Give me your guidance. That's a new trend for us. We are all old.
I know.
We are all old in that. We're not used to that. So you
So
genuinely just
luckily my last election was uncontested, so
give me.
I've forgotten how
Yeah,
to
I know. That's what I'm
contest
saying. It's quite because we are not used to such things, right?
True.
So anyway, I'll try to do my best.
Sure.
Dr. Murali?
Yeah.
I am going to contest for the committee of medical disorders in pregnancy. I need your support.
Of course.
You should promote me.
Yeah. No doubt in that.
Yeah, so I think we can start now.
Yeah, we'll start.
Join, yes.
Arun?
Yes, ma'am.
Arun, please unmute others and play the prayer.
Arun, you can start the prayer.
Yes, you can start the prayer.
1 minute, sir. I am muting all.
Yeah.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Namaste and a very warm welcome to all of you. On behalf of the Karnataka College of Obstetricians and Gynecologists and the Karnataka College, that is KCOG, Cpap program, I extend a warm welcome to all of you. At the outset, we would like to apologize for the absence of our Chief Patron, Dr. M.G. Hiramat, and our President, Dr. Basuraj Sajjan, due to unavoidable circumstances. I extend a warm welcome to the Chairman of KCOG, Dr. Muralidhar Pai, to this one more very useful program on management of postmenopausal bleeding. And it is indeed a pleasure to have Dr. Parag Biniwale time and again with us, a very pleasing personality with a lot of inputs. He will be with the speaker today to speak to us on the management of postmenopausal bleeding. I extend a warm welcome to our treasurer, Dr. Durgadas Asrana, Dr. Vidyapat, the secretary of KCOG, and all the members of the participants who have logged in to this very important KCOG program, that is the Cpap program, that is the Continuing Professional Advancement Program, a need of the hour, because with the umpteen number of updates and the changing protocols in the management of postmenopausal bleeding, I think this talk today by Dr. Parag is going to be very useful in our clinical practice. I welcome one and all to this, and I now request Dr. Muralidhar Pai, the chairman of KCOG, to kindly introduce, to say a few words and then introduce the guest speaker, Dr. Parag Biniwale.
Thank you, Dr. Bharati. And as all of you know, that Karnataka College of Obstetricians and Gynecologists has got different types of programs. The first Tuesday of every month is the program called Cpap, that is Continuing Professional Advancement Program, wherein we target the practicing gynecologists with the eminent speakers in the country and eminent practitioners who would be dealing with the different management protocols. The second Tuesday of the month will be on the skill learning that is handled by Dr. Vidya Bhatt. And then the third Friday, we are going to have the international speaker, wherein our Dean of the college, Dr. Hema Diwakar, is the coordinator. And finally, we have one more week wherein we are going to promote the young speakers. So today we are fortunate to have a very good clinical practitioner from Pune, Dr. Parag Biniwale. Arun, can you please put up the, yes. So Parag Biniwale, as Dr. Bharti told, he's a very pleasing personality. Even though he's a senior consultant Pune, he can adjust to any level of people. Very simple, very humble. Is a teacher and unit head at Kamala Nehru Hospital, vice chairperson of ICOG currently, and he's the president of Menopause Society Pune, president-elect Pune OBG Society. He has been secretary of ICOG between 2018 and 20, national website editor of Foxy between 2011 and 17, peer reviewer of Journal of OBGYN of India for same 5 years, chairman Young Talent Promotion Committee 2008 to 10, co-editor of book Gynecological Manual on Adolescent and Yearbook of OBGYN 2019. Contributed articles to books and journals, delivered orations, guest lectures in over 130 Foxy societies. It speaks for his erudite, his clinical skills, and today we are fortunate that he'll be talking on the management of postmenopausal bleeding. Over to you, Parag.
Thank you, Dr. Muralidhar Pai, for those kind words. Good evening. I bring greetings from Pune, and it's indeed an honor to be speaking in the Karnataka College of OBGYN. So thank you, Chairman Dr. Muralidhar Pai, Secretary Dr. Vidya Bhatt, and of course, Team Ksoga, Secretary General Dr. Bharti, and all for giving me this opportunity to talk to everybody. Right, in next half an hour, I'm going to talk about one problem which puzzles a lot many times, and that is postmenopausal bleeding. Now, we know that when a woman ceases to have menses, we say that she's become menopausal. And whenever there's any bleeding or vaginum in a menopausal woman, we are concerned because we may be dealing with some critical situations like malignancies, or even we may be dealing with something like atrophic changes. But here we must remember that if the woman is taking menopausal hormone therapy, the cyclical pills, then this need not be included in postmenopausal bleeding. World over, it is estimated that the incidence of postmenopausal bleeding is about 4 to 11%, but the Indian Menopause Society incidence says that it is about 10 to 15%, and it is much higher than what it is world over. And that's probably because the age of menopause in our country is almost 5 years less as compared to the Western world. So when we talk about postmenopausal bleeding, commonest reason probably is the atrophic endometritis or vaginitis, which contributes to almost 60 to 80%. It could be endometrial carcinoma in about 10%. That is what we are worried about. Exogenous estrogen contribute to about 15 to 25%. And of course, we cannot forget endometrial hyperplasias and endometrial or cervical polyp. Coming to the first pathology, that is atrophy. And we know that hypoestrogenism is the one which is the hallmark of menopause. And it does cause changes in the endometrium and in the atrophy. The endometrial surface usually is collapsed, and the result in microerosions of surface epithelium and a subsequent chronic inflammatory reaction, that is chronic endometritis, which is prone to bleeding or even spotting. So classical vaginal findings of atrophy will include a pale, dry vaginal epithelium, and of course, we will be talking about it in a bit. The second reason is cancer, and that is what we are worried about. The incidence again varies from country to country, but overall 6 to 19% women may have some form of cancer, endometrial cancer being probably the most common. The risk was 19% in women with both postmenopausal bleeding and when the sonography showed endometrial thickness of more than 4 to 5 millimeters. The risk of endometrial cancer in the setting of postmenopausal bleeding increases with increasing age after menopause. And in women over 55, history of recurrent bleeding episodes and bleeding volume that exceeds about 5 pads a day were significantly associated with presence of endometrial cancer. There are other causes like polypi. We know that polypi are the benign growths, perimenopausal women, but also noted in postmenopausal women. And here we must not forget these polypi could be secondary to estrogen therapy or more commonly in tamoxifen therapy offered to women who undergo treatment for carcinoma of breast. Postmenopausal hormone therapy, we know that many postmenopausal women who take estrogen therapy may develop this, and the frequency will depend on the regimen that is used. Typically, we do not expect the endometrium to be hyperplastic in postmenopausal women, but this is something which we have to keep in mind because we know that postmenopausal women will be estrogen deficient and hyperplasia should have abundance of estrogen. So endogenous estrogen production from ovarian or adrenal tumors or exogenous estrogen therapy are the possible causes of endometrial hyperplasia. And let's not forget that obese women will have high levels of endogenous estrogen due to conversion of androstenedione to estrone and the aromatization of androgen to estradiol, both of which occur in the peripheral adipose tissue. Leiomyoma uteri, again, one of the most common tumors, pelvic tumors in women, seen in about 25 to 30% women overall. The prevalence in postmenopausal women is rather uncommon, but here we have to keep in mind that it could be a cause of bleeding in some women. The diagnosis of uterine sarcoma should be considered in postmenopausal women with presumed uterine leiomyomas producing symptoms, and the incidence of sarcoma is higher in this group, but the overall percentage is much lower. Adenomyosis, again, something peculiar to menstruating women. We know that there is a lot of pain and heavy menstrual bleeding during reproductive years, but sometimes women after postmenopause may experience some amount of bleeding, which could be because of adenomyosis, not a very common occurrence. Let's not forget diseases in adjacent organs, that is inflammation of neighboring organs such as diverticulitis, which can occasionally cause a corresponding inflammation of the upper genital tract. Sometimes a ruptured sigmoid diverticulum may fistulize into the uterus and present as uterine bleeding, discharge, and endometritis. Diseases of urethra, that is urethritis, bladder, which could be urinary tract infection more commonly, rarely cancer of the bladder, and inflammatory bowel disease or hemorrhoids can contribute to bleeding, but it may be mistaken for genital tract bleeding. And of course, examination will tell us. And let's not forget the post-radiation therapy women who undergo radiation for pelvic malignancy may experience some amount of tissue necrosis, which causes viscous perforation, tissue sloughing, and bleeding. And hemorrhagic cystitis and proctitis can also lead to significant blood loss. And let's not forget that the vaginal vault necrosis may at times cause uncontrolled bleeding and pain. Anticoagulant therapy, herbal dietary supplements are something which we have to keep in mind. Not a very, very common occurrence, but yes, a possibility. And endometritis is rather uncommon in postmenopausal women, but should be kept in mind occasionally. So whenever we get a lady who comes to us with a history of menopause and bleeding, the first question that we would ask her, what was the age at menopause? When did the bleeding start? Were there any precipitating factors such as trauma? And here, let's not forget the postcoital bleeding, because if there is atrophic changes of the vagina, even a forceful coitus can cause a lot of bleeding. What was the nature of bleeding, the duration, quantity? Was there associated symptoms like pain, fever, etc.? About the medical history and any medications being taken, we know that C. endometrium would be more common in women who have diabetes and hypertension. Is the woman taking any soy-containing herbal or dietary supplements? And we must also inquire about the family history of breast, colon, and endometrial cancer. So we have to be on guard in women who are obese, who are diabetic, and using tamoxifen, because these are the risk factors for endometrial cancer. Vaginal dryness, soreness with dyspareunia, and bleeding after intercourse would suggest atrophy. And a foreign body may be a source of bleeding in a woman who uses a pessary. And let's not forget those forgotten intrauterine devices, which may occasionally come to us with postmenopausal spotting most of the times, but rarely bleeding. When we examine, noting BMI is important, blood pressure it has to be noted. Thorough physical examination is important. We must have a good look at the external and internal genital organs. The focus of evaluation is to determine the bleeding site or to note any suspicious lesions, lacerations, and foreign bodies, and of course, to assess the size, contour, and tenderness over the uterus. We must also rule out the bleeding from lower genital tract, that is vulva, vagina, or ectocervix, and this can usually be excluded by a normal physical examination. And let's not forget the bleeding through anus and urethra. So these are the basic investigations which we would recommend to any woman who comes to us with menopause. So these women also should be advised these minimum set of investigations. The next important investigation is to do a cervical cytology. We know that the mean age of cervical cancer is around 52 years. It means that in our country, it's almost 6 years after menopause. So all women need cervical cancer screening as a part of evaluation of abnormal bleeding. And as it can be difficult to distinguish between endocervical and upper uterine bleeding, we know that we always take 2 samples, the ectocervix, which is taken by a spatula, and the endocervical sample, which again is very, very important in women who come to us with postmenopausal bleeding. And please note that if there is any visible lesion, it needs to be biopsied, even if the cytology is normal. So when we look at these cells, we also look at the glandular cells, and they are pointers for endometrial pathology. So whether we are getting any atypical glandular cells or endocervical cells, or even we are getting frank cells which are representing adenocarcinoma, this is something which has to be noted very, very clearly, and it is prudent that an experienced pathologist examines the smear very, very diligently. So if the cytology shows presence of abnormal glandular cells, that is endometrial cells, presence of AGC, all subcategories other than endometrial, or presence of benign appearing endometrial cells in a woman who's more than 40 years, we must suspect endometrial cancer, and biopsy is what is recommended. Coming to the role of ultrasound, a transvaginal ultrasound is important, where we look at the uterine size, very importantly, the endometrial thickness, and polyp can also be diagnosed along with other pathologies on a good transvaginal ultrasound scan. 3D in postmenopausal women has a limited role, but saline infusion sonography will offer us better visualization of intrauterine pathology. So coming to endometrial thickness, we know that in a postmenopausal woman, the endometrial thickness of 4 or less is what is expected. And this has to be measured rather correctly. So endometrial thickness is measured as the maximum anteroposterior thickness of endometrial echo on a long axis transvaginal view of the uterus. So this is extremely important. In an asymptomatic early postmenopausal woman, an endometrial thickness of more than 11 should prompt us to have an endometrial biopsy. Of course, here putting a hysteroscope would also make sense. An endometrial thickness of more than 3 to 5 millimeters in transvaginal ultrasound should also warrant an endometrial sampling. Coming to the use of transvaginal ultrasound for evaluation, and this is the latest reference, August 2021, and it says that for the initial evaluation of patients with postmenopausal bleeding, use of transvaginal ultrasound to measure endometrial thickness and determine which patients require endometrial sampling is an acceptable alternative to endometrial sampling alone. So only sampling is what is not recommended. A transvaginal ultrasound followed by endometrial sampling. And in a retrospective study, which had about more than 300,000 patients with postmenopausal bleeding, women who underwent biopsy at an endometrial thickness of more than 4 millimeters missed more cases of endometrial cancers in black patients than in white patients. And the greater prevalence of fibroids and non-endometrial tumors in black patients may also contribute to this disparity. Coming to the endometrial biopsy, so when the endometrial lining is thicker than 4 millimeters, when the endometrium shows diffuse or focal increase echogenicity, if the endometrium is not adequately visualized on sonography, endometrial biopsy is recommended. The woman has persistent bleeding, and if this bleeding can be a sign of endometrial cancer, even if the endometrial thickness is less than 4 to 5 millimeters. So here, even though the endometrium appears to be thin, it is worthwhile considering the diagnosis of endometrial cancer. And the sensitivity of detecting endometrial cancer at 3 millimeters is about 98%, 4 millimeters is at about 95%, and at 5 millimeters is about 90%. And in women with homogeneous and normal morphology, those on MHT and hypertensive medications, the acceptable combined thickness is about 6 millimeters. So what is the next step that we need to do? So outpatient endometrial sampling devices such as Cpap in low-risk women and with global pathology may be used. Outpatient hysteroscopy is preferred method for endometrial sampling, especially if the endometrial biopsy tissue is reported as insufficient for diagnosis, or if the endometrial thickness is less than 4 millimeters. And recurrent episodes warrants further investigations. Coming to the Cpap, and here this is something which has really changed our way of practicing, because this is something which can be performed on an OPD basis. No local or no general anesthesia is required. Cervical dilatation is usually not required, and performing the procedure in an office setting is definitely less expensive than a procedure in operating room. When we are doing it in our clinic, we are, in most of the patients, we are offering a tablet of misoprostol about 45 to 60 minutes before the procedure. It definitely hastens the procedure or makes it more painless as far as the endometrial biopsy is concerned. Coming to the efficacy of Cpap, because whenever we are using a very tiny instrument like this and putting it blindly inside the uterine cavity, we are worried about its efficacy. But in a meta-analysis of 39 studies involving more than 7,900 patients, where the results of endometrial sampling with histopathology at DNC, hysteroscopy, and or hysterectomy, this was what was noted. The Cpap device was found to be more sensitive for detection of endometrial cancer and atypical hyperplasia than all other sampling devices. The sensitivity for diagnosis of endometrial cancer by Cpap in postmenopausal bleeding was 99.6%, and in premenopausal women it was 91%. So it makes us more confident that in a woman where you are suspecting endometrial cancer, maybe first line therapy would be to do, or the first diagnostic modality would be to do a Cpap outpatient sampling. The specificity for all endometrial biopsy devices for the diagnosis of endometrial carcinoma was 98 to 100%, and fewer than 5% patients had an insufficient or no sample. So whenever we are using this tiny device, we are also concerned about the amount of tissue that we get for histopathological examination. But mind well, the kind of tissue that is retrieved by this tiny device is really adequate for its proper assessment. So what is the role of hysteroscopy? We know that hysteroscopy has several advantages. It gives us immediate office evaluations, especially in high-risk patients. And if you're doing it as an office procedure, you can avoid a general anesthesia. Visualization of the endometrium and endocervix is done in a better way. It has the ability to detect minute focal endometrial pathology and perform directed endometrial biopsy in the same sitting. So there is a less possibility of you missing out endometrial malignancy, which may be in a corner of the uterine cavity. And it has greater accuracy for intracavitary lesions. The sensitivity is about 97 to 98%, but it is rather expensive, and the results are dependent on the operator. So if the operator is a skillful one or an experienced person, then obviously you will get better results. So coming to hysteroscopy in postmenopausal bleeding, and this is what a study from my own city said. What they found out was none of the patients up to 49 years of age had endometrial carcinoma. Factors such as obesity, diabetes mellitus, nulliparity, hypertension was significantly associated with postmenopausal bleeding. Atrophic endometritis was what was found most commonly, followed by endometrial cancer and polyp. When correlating TVS and hysteroscopy, they found out that hysteroscopy was more specific and sensitive, and hysteroscopy can be considered as the simple, safe, effective, and a first-line gold standard method for evaluation of postmenopausal bleeding. And we know these are the pathologies that we can see when we peep inside the uterine cavity. So once you establish a diagnosis, the treatment has to begin as per your diagnosis. So atrophy is something which is most common. IMS reports the incidence to be about 15%. It usually presents as vaginal dryness, pruritus vulvae, and dyspareunia. About 10% women will have urinary urgency and urogenital atrophy as a result of declining estrogen levels, and it also may present as recurrent urinary tract infections. So this is how the clinical picture would look like. There would be physical signs of vulvovaginal atrophy, which are variable, and they may include reduced vulval fat, reduced vaginal rugae, and of course blood flow leading to a pale appearance. So a gentle speculum examination would be of great help. Change from moderately acidic range to a neutral range where because of the shift in the vaginal maturation index. So this is something which can also point us that the woman is suffering because of the atrophic changes. Coming to the management, vaginal lubricants can be recommended for subjective symptom improvement of dyspareunia. Vaginal moisturizers can be offered for vaginal dryness and dyspareunia. Local estrogen therapy is the first line treatment for atrophic changes. Lifestyle modification, bladder drill, and pelvic floor exercises are definitely recommended for urinary incontinence. What are the benefits and risks of local therapy? Local therapy is indicated when woman suffers only from urogenital atrophy. Vaginal estrogen therapy is the most effective treatment in urogenital atrophy. So low dose preparations are as effective as systemic therapy. In fact, oral estrogen therapy may not give as much relief as a local therapy. And low-dose vaginal estrogen formulations reported no incidence of increase in CHD, stroke, and VTE. and there are no contraindication for its use in non-hormone dependent cancer. So for a woman who comes to us in postmenopause with atrophic changes, we should be rather confident in using local estrogen therapy to relieve symptoms because of atrophy. So these are the regimen for local therapy for genitourinary syndrome of menopause, and this is I've taken from the recommendations of Indian Menopause Society. So for correction of deficiency, estriol cream 0.5 milligrams per day of vaginal application, or conjugated equine estrogen 0.3 to 1.25 milligrams per day of vaginal applications for 15 days. And the maintenance therapy should continue as estriol cream 0.5 milligrams or conjugated equine estrogen 0.3 milligrams twice weekly for about 2 months to 1 year. Of course, these women have to be monitored on an OPD basis for their beneficial effect of local therapy. When you're thinking about systemic therapy, one thing that we have to remember is that if the woman is not hysterectomized, then we must add appropriate progesterone, and studies have found out that micronized progesterone and dydrogesterone are much better than medroxyprogesterone acetate, which we used it for many years earlier. And levonorgestrel intrauterine device also has some role to play in protecting the endometrium from continuous stimulation of estrogen. This is what the management of GSM looks like. And whenever we have a woman who comes to us with postmenopausal bleeding, do an examination, assess for vaginal atrophy. If there are infections or vulval region, they need to be diagnosed and treated appropriately. Coming to the next condition, that is CA endometrium, and we know that there are so many risk factors like obesity, unopposed estrogen, tamoxifen therapy, late menopause, women who have polycystic ovaries, diabetes mellitus. All these women do definitely have a higher risk of developing CA endometrium, but we have to remember is the risks which are modifiable. So we must counsel younger group of women who are obese, who are diabetic, with hypertension, or maybe suffering from polycystic ovarian syndrome, to have a good lifestyle modification in the younger age group in order to prevent issues because of endometrial cancer. And of course, a strict no-no to unopposed estrogen therapy when the uterus is intact. But there are some factors which, of course, we cannot modify, and we have to be vigilant in these women in diagnosing and taking a good prompt action in order to prevent the problems of endometrial cancer. This is the FIGO staging, and you will agree that if we detect this particular condition in the first stage, the 5-year survival rate is almost 85%, which is really good. So it is definitely important for all of us to act quickly in these women and prevent or diagnose endometrial cancer in an earlier stage. These are the list of imaging techniques which can be used for diagnosis and management of endometrial cancer. For women with suspected endometrial cancer or even hyperplasia, pelvic sonography is the first line therapy. This we all have agreed. In the infrequent situation in which a patient is staged clinically, a contrast enhanced MRI appears to be the best sonographic modality for detecting myometrial invasion or cervical involvement when compared with non-enhanced MRI, ultrasound, or CT. So MRI in these women will definitely tell us about the involvement of myometrium, involvement of the cervix, and then it will help us plan the surgical management much better. A chest radiograph should also be performed. A PET scan has utility in detecting occult lesions. Coming to the surgical management, I'm not going in details, but this is what is followed. After basic investigation, we may think of doing endometrial sampling, surgical staging and therapy, and then it is followed by exploratory surgery, that is laparotomy or even laparoscopy. Mind well, as compared to CA cervix, C endometrium can better be handled with the help of laparoscope. Peritoneal washings should be taken wherever necessary, and whenever we are offering surgery, of course, hysterectomy with bilateral salpingo-oophorectomy, and depending on the disease, lymphadenectomy should be performed. So these are some of the important points we must remember for CA endometrium, that surgery constitutes the definitive primary treatment for most of the patients with endometrial carcinoma. Primary radiation therapy and primarily hormone therapy are alternatives for inoperable patients or women who are not fit to undergo a major surgery. For women with low risk endometrial cancer, no additional treatment is required after surgery because their prognosis is excellent. Women with intermediate risk diseases are candidates for adjuvant radiation therapy, and women with high risk disease may require chemotherapy with or without radiation therapy. Coming to the unusual problem of endometrial hyperplasia, and these are the risk factors for hyperplasia. Mind well, the risk factors for endometrial hyperplasia are more or less the same as that of CA endometrium. But before we move ahead with the treatment, the classification or the terminology is something which we have to remember. There was a time when we always classified the endometrial hyperplasia as simple, complex, with atypia, without atypia. But now, since 2014, WHO classifies endometrial uterus may not be enlarged or may not be tender. The laboratory results are usually normal, except for patients with substantial abnormal uterine bleeding who may be anemic. As far as imaging is concerned, in postmenopausal women, ultrasound may demonstrate an increased endometrial thickness with cystic features and heterogeneity. However, ultrasound criteria have not been set for detection of endometrial hyperplasia as they have for endometrial carcinoma. Thus, endometrial thickness in a postmenopausal patient in the absence of bleeding is a non-specific finding, but one is that requires further evaluation for endometrial hyperplasia. Coming to the management, and when we talk about management, the patient with endometrial hyperplasia should be assessed for reversible risk factors and receive education and support from their clinicians in order to treat and reverse those conditions. Patients with endometrial hyperplasia without atypia can be observed. They can be offered hormone therapy if hyperplasia does not resolve with observation or experience abnormal uterine bleeding. The levonorgestrel intrauterine system can be used as the first line therapy like we use in women in the reproductive age group. Now here we must remember that it can be used in women without atypia. It is effective, it is favorable, and there is enough evidence of its use and efficacy in treating endometrial hyperplasia. We know that it can be kept in place for about 5 years. There are now studies which talk about extended use up to 7 years. Low dose oral and injectable progestin remain an acceptable treatment option for women with endometrial hyperplasia with and without atypia desiring an alternative treatment modality. For patients on oral progestin, starting on low dose for minimum of 6 months, assessment of endometrium should be done mid-therapy as well as 3 weeks after completion of therapy to ensure proper interpretation. Coming to the surgical treatment, and surgical treatment for women who have endometrial hyperplasia without atypia should be offered to women who do not want to preserve their fertility and experience progression to atypical hyperplasia or carcinoma during follow-up. Women whose hyperplasia fails to regress after 12 months of medical therapy, or women who continue to experience abnormal uterine bleeding despite proper treatment, and women who decline endometrial surveillance or medical treatment. Mind well, whenever you are offering a conservative treatment for endometrial hyperplasia, a repeat biopsy at at a suitable period, which typically is about 6 months, is what is recommended. Coming to hysterectomy, and if surgery is indicated for endometrial hyperplasia without atypia, procedure should include total hysterectomy with opportunistic salpingectomy with or without bilateral oophorectomy, depending on the menopausal status. And it is prudent that we counsel women before we take out their ovaries. Total hysterectomy with bilateral salpingo-oophorectomy is recommended for treatment of atypical hyperplasia in premenopausal and postmenopausal women, and in premenopausal women, ovarian preservation should be discussed. The SOGC, that is the Canadian Society, recommends to avoid subtotal, that is supracervical hysterectomy, and morcellation, even in cases of endometrial hyperplasia. Coming to cancer cervix, it can seldom be cause of postmenopausal bleeding, especially if women come to us as postcoital bleeding. We must not forget the additional risk factors, which would include smoking, history of OC pill use, multiple sexual partners, and early age of intercourse. A good examination is important. So once we put in a speculum, we may be able to see the cervix and along with the mass and its extent, and a rectovaginal examination to evaluate for spread of the disease into the parametrium or to the pelvic side walls. And biopsy of abnormal lesion should be done to confirm diagnosis. When we have a lady who comes to us with a cervical pathology, this is the flow chart that needs to be followed. The first line, of course, would be to do a pap smear and HPV testing, and then colposcopic evaluation is important. And depending on the diagnosis, we take a call as to what is to be done further. So if these tests are negative, we can observe women. If there is cervical dysplasia, management should be done as per guidelines. And of course, if she is diagnosed to have cancer, surgical or gynae oncologist opinion has to be taken in order to how to manage it further. And this is what is the standard treatment for CA cervix. Radical hysterectomy, trachelectomy, pelvic node dissection all have its own place. And in advanced cases, concurrent chemoradiation may also be required. So to conclude, postmenopausal bleeding refers to any uterine bleeding in a menopausal woman other than the expected cyclic bleeding that occurs in women taking cyclic postmenopausal hormone therapy. Endometrial atrophy and endometrial polyp are the most common causes of postmenopausal bleeding. Endometrial carcinoma is seen in few women. For women who are not taking menopausal hormone therapy, the risk approximately is about 12%. The primary goal in the diagnostic evaluation of postmenopausal women with uterine bleeding is to exclude malignancy. So either endometrial biopsy or transvaginal ultrasound can be used as initial test for evaluation of endometrium. Traditionally, we do a transvaginal ultrasound first, followed by endometrial biopsy. Uterine bleeding in postmenopausal women is usually light and self-limited. Exclusion of cancer is the main objective. So treatment is usually unnecessary once the cancer has been excluded. So further diagnostic evaluation is indicated for recurrent and persistent bleeding. And I would share some of these evidence-based guidelines for everyone. So MHT should include a progestogen containing regime, which is protective against the endometrial effects of unopposed estrogen. Postmenopausal women receiving tamoxifen therapy, particularly for longer than 5 years, are at increased risk of endometrial cancers, and we have to counsel them, monitor them very, very carefully, and take prompt action at the first go. Office endometrial biopsy should be the first line investigation for whenever we are doing the workup for postmenopausal bleeding. Hysteroscopy guided biopsy is the gold standard for investigation of postmenopausal bleeding. Whenever sufficient local skills and capacity exists, a transvaginal ultrasound as an appropriate alternative first-line procedure to identify which women with postmenopausal bleeding are at higher risk for endometrial cancer. Hysteroscopy and biopsy is the preferred diagnostic technique to detect polyp and other benign lesions, and D&C should no longer be used as the first line method of investigating postmenopausal bleeding in most cases. So once again, thank you to the Karnataka College of OBGYN for the invitation and giving me this opportunity to have a dialogue with you. Thank you very much.
Thank you very much, Parag. You have made it look so simple and easy. And that's the art of a good speaker. I agree with you that thankfully, most of the time, all postmenopausal bleeding is not due to cancer. But it is our duty to make sure that we don't miss a case of cancer. The problem is sometimes, this atrophic endometrium gives rise to postmenopausal bleeding. And we all know that it is due to estrogen deficiency. The problem comes in treating that. You touched upon a little bit of that. Can you elaborate more? Because it will be like a, you are either on this side or that side. When we treat it with estrogen, there will be more problems again.
True. So whenever we are treating women who have atrophy, and whenever you're offering them, say, oral estrogen, then I think it is a good idea to add progesterone to protect the endometrium. But here, counseling is extremely important, because woman who has attained menopause, you have to tell her that she is likely to restart her menses again.
Yeah.
And if this is if you counsel it well, most of the women accept it as it is, and then you can continue therapy for a short duration of about 3 months. Evaluate her again after 3 months as far as the symptomatic relief is concerned. And of course, after 3 months, we would certainly have a look at the endometrium also.
Yeah. So if it is not much or heavy, can we just say that expectant or just observation should be, or use a pad should be the...
Absolutely. So again, counseling her, reassuring her that, that this is because of the atrophic changes, because there is of hormone depletion. And even if it recurs, there's nothing for the lady to worry. There's no disease, though it may cause some amount of inconvenience, because after having menopause, starting to use pads again may not be a very comfortable feeling for a woman. But if you counsel her well, I think they would accept it in a better way.
There are a couple of questions in the... can I ask Bharati, or should
you? Yes, sir. You go ahead. I wanted to tell him there's a continuation of the same question. You can ask him.
Yeah. No, there is a question. What to do if there is white discharge postmenopausally?
White discharge?
Yeah.
We have to diagnose and treat it. If there is recurrence, then probably now, in fact, there are some gloves also available, something called Ivanu Glow, which will tell us about the pH. Of the vaginal secretion. So that can also be a pointer if specifically if the woman has recurrent vaginal infection. So it may help, apart from the look of the discharge, it will also help us by giving us the pH. So we are in a better position to differentiate whether it is because of candida, whether it is because of trichomonas, or it is because of bacterial vaginosis.
Yeah.
So
there is one
specifically, we will be able to treat it better.
Yeah. There's one more question from Parinita Ajay. She's asking which oral progesterone is preferred to decrease the endometrial hyperplasia.
Dydrogesterone and is probably the safest if you are thinking of vaginal micronized progesterone. Both these have been used in hormone therapy in the postmenopausal women, and they are found to be friendly as far as the lipids are concerned. They are found to be friendly as far as the breast is concerned. So if you remember, if I take you back a little bit, when I say little bit, almost 20 years back, with the WHI study, which shook all of us and the media as well.
And medroxyprogesterone was the culprit.
Medroxyprogesterone acetate was the progesterone that was used, and the study arm where conjugated equine estrogen and medroxyprogesterone was used, there was higher incidence of VTE, there was higher incidence of CA breast. So, people were really taken aback about hormone therapy, and all of you will agree that even we as clinicians started using lesser and lesser amount of menopausal hormone therapy, so a lot of women were deprived at that time. But now, when you look back and the scenario has changed, the concepts have changed, and we can certainly offer better and safer drugs to women in postmenopausal period.
Yeah, I'm just asking, suppose it is just a endometrial hyperplasia without cancer. Is Mirena okay in a postmenopausal lady?
Absolutely,
Because,
absolutely. But the general recommendation is, even if you use LNG intrauterine system, the surveillance has to continue, and you should do a pipelle biopsy every 6 months. Of course, we would prefer to combine it with a transvaginal ultrasound as well. And basically, the aim is to monitor whether the disease is progressing. If it is regressing, well and good. If it is progressing to atypical hyperplasia, then probably we need to rethink about the treatment that we need to offer.
And Galaxy A31 is asking, I don't know the name. So they have not enrolled the name. So will hysteroscopy cause spillage of malignant cells?
Okay, that was something which was debated for many years, and I'm sure we have Vidya here, who is an expert hysteroscopist,
Vidya has
and
gone
she
to
will
the
also
OT.
agree.
Vidya has gone to the OT on an emergency.
Oh, she's gone to the OT.
But in an office hysteroscope, you may not use any.
I don't think so. No. There's enough
use
literature which says that it is very safe and it does not cause any spillage as far as the
you don't
endometrial
even
cells
have
are
to distend the cavity so much in an office hysteroscope.
Not really.
Yeah. So the next question is incidental detection of increased ET in postmenopausal women. What are the cutoffs to evaluate, sir?
Okay, now if
she doesn't have basic bleeding, but incidental finding.
Okay, now see, the basic cutoff for a normal menopausal woman is about 4 millimeters. If the endometrial thickness is more than 4, we need to be vigilant. We have to counsel the patient that she has to come back for a review after about 3 months, do a good transvaginal scan again. And if the endometrial thickness does not increase, we can reassure her and she can come back for a regular follow-up every 3 months. But if the endometrial thickness keeps on increasing, then it warrants endometrial sampling. But otherwise, I don't think it requires too much attention.
That question was asked by K. Ganesh Bhatta, who actually is very active. He was active during our We Care program, and he's active now also.
I think he has another question.
Dr.
Ganesha Bhatt has posted another question, Dr. Murli.
What is that?
He has, Dr. Ganesh Bhatta asks that even if the endometrial thickness is less than 4 millimeters and the patient is symptomatically bleeding, doesn't it warrant a biopsy?
Yeah. It does. In
Whenever
fact,
there is
in one of my slides,
endometrial thickness is mainly a cutoff. Yeah, Parag.
Yeah. No. See, and though it is expected that in endometrium, we expect the endometrial thickness to be more than 4. In one of my slides, I did mention that if she continues to bleed, then it definitely requires attention.
Yeah, any symptomatic patient should be biopsied.
Absolutely.
The endometrial thickness is considered only if she is not symptomatic, but she incidentally we find that that is the time. And DNC is recommended. Is DNC recommended in postmenopausal bleeding and cutoff of endometrial thickness? You have clearly mentioned DNC has no role. They are asking the to make it doubly sure. Yeah. And same person, Dr. Usharani continues to ask, can we take pipelle biopsy with LNG in situ? Will we get adequate sample?
It depends on the amount of endometrium that is present. Now we expect that when we insert LNG IUS, with the continuous release of progesterone in 6 months, we expect the optimum result to start. So if the endometrium really becomes thin, then we may not get any sample. But if the endometrial still remains thick, we may get endometrial sample.
Thank you. Dr. Durga Das Asrana is asking double question mark tubercular causes.
Yeah, that is something which in our country we have to keep in mind.
So, okay.
But I have never seen any patient, unfortunately. Maybe Murli, you may have seen patients in
really.
Manipal, but somehow I have not seen any
No.
lady with postmenopausal
No.
bleeding with
No, it is
endometrial tuberculosis.
another point is that tubercular endometritis may cause amenorrhea, which we may mistake for menopause. That is there. And then, of course, because of the thin and atrophic endometrium, again, sometimes there will be breach and there will be bleeding. And again, but for the treatment of that, of course, is again, anti-tubercular rather than anything else. And I think those are the questions, but there are many congratulatory notes to you, Parag. That means it is a very, very good talk that you have given, very comprehensive. Parag is Shobha Gudi, what is she saying? And Dr. Vidya Tobi is telling excellent talk. And our own Dr. Bharti is telling excellent talk. Dr. Parag covered all issues very concisely. And Dr. Ganesh Bhatt also is telling a very informative session, sir. And I am telling you that it was excellent.
I think Ganesh Bhatt has another
Shobha
question.
and Vidya are very dear friends, and they always encourage me to do better. So I must acknowledge and thank them for being here today.
Look at that.
Dr. Parag, there's another question by Ganesh Bhatta. What is the significance of fluid in the endometrial cavity?
Yeah.
Okay, now whenever you have a postmenopausal woman with a fluid, here again, I think cytology first would be of great help. And we must keep in mind that possibly we are dealing, especially if she comes with pyometra or hematometra in a postmenopausal woman, we have to first think of endometrial cancer. So that is something which we have to keep in mind. And over here, depending on the situation, we may do a hysteroscopy or even Pipel endometrial biopsy. So hysteroscopy probably would make sense in such situation.
Dr. Shobha, would you like to give any comments?
Shobha, Dr. Vidya Tobi is also there.
Yeah, Dr. Vidya
Durga
ma'am.
Das.
Seeing you after a long time, Vidya ma'am.
Yeah, Parag, that was a very comprehensive talk. Just wanted to share my experience with postmenopausal women who require Pipel. I think sometimes it is very tough to do an outpatient Pipel in them, and we do insert some misoprostol. We tell them to insert around 5 a.m. and then report to the OPD by 9 or 10. And then we find that it is fairly easy to get a sample. The other thing I wanted to share is the perimenopausal women who have been put on LNG-IUS as treatment for endometrial hyperplasia without atypia. We find that, as you also rightly said, that doing a Pipel by the side of the LNG-IUS is actually an excellent method. And we combine it with imaging so that we don't miss anything. And we have found that high reassurance value, and quite a lot of time we find reversal. We find just proliferative or decidualized endometrium, and like that we find. So, and
that reassures us that LNG is actually getting released in the uterine cavity. Right. Shobha, you did talk about the endometrial, the cervical stenosis at times. So, women who have had previous C-section, maybe one or two or more, we ask them to come down to OPD about 2 hours before, and instead of 1, we've tried giving them 2. So in most of the patients, we are able to do a Pipel, but very rarely we may have to think of doing a dilatation. But then if at all you have to do a procedure under anesthesia, you might as well put in a hysteroscope in the same sitting, rather than doing only a Pipel biopsy under anesthesia. The advantage of Pipel is that, you can do it in your clinic setting and get adequate information about the endometrium, and then you can take it further.
Dr. Pai, I also wanted to give one message about office hysteroscopy, and it is of particular use for evaluation of postmenopausal women. Office hysteroscopy, though it may not allow us to do curettage or any hysteroscopic procedures. It will give us a fair idea as whether we have been complete in our assessment by just taking one sample of them. it's very useful actually. So now office hysteroscopy is actually, a lot of practice is there for that. Probably isn't it, Dr. Parag?
Yes.
Yeah, I
in
personally have
postmenopausal in
very little
menopause
experience
clinics, yeah.
of office hysteroscopy because in my clinic I do not have one. Just one more comment I thought I'll just make. In COVID times, especially, there were few patients who opted for a PIPEL. When we were just counseling them, we in fact told them that PIPEL may not be the best available thing, but in COVID times when the patients were reluctant in getting admitted to a hospital for postmenopausal bleeding, we did offer them PIPEL, and luckily for us, PIPEL was quite conclusive. None of them had C endometrium, but that was something which we observed in last 1.5 years of COVID.
Okay, Dr. Bharati, can we hand over to Dr. Durgadas Atsarana for the vote of thanks?
Yes. Dr. Durgadas.
So
Yes. Yeah, Dr. Parag, it was an excellent talk. So you told that you have in the election you have won without any contestants.
That is
because of your work. What election?
Previous, not this time. Dr. Durgadas, that was when he was ICOG chairman.
Previously.
Previously.
Because as ICOG secretary, he has done an excellent job. That's what I am telling.
Thank you.
He has taken the ICOG to the doorsteps of all the Caucasians. That made him so popular.
Thank you.
Just because he was such a beautiful, very good teacher, which he has proved it today. Your talk was very lucid. You had touched the basics, and really we all enjoyed your talk. Thank you very much for sparing time and joining us today. Thank you very much, Parag. Yeah.
So we'll
thanks.
Yeah. Continue.
Bye.
Thank you.
Bye. Thank you for joining all the way from Sikkim. Thank you very much. We thank our own secretary, Dr. Bharati Rajshekar. He's a really dynamic secretary we are having. I also thank Dr. Shobha Gudi, Dr. Vidya Tobi, and all the participants of today's evening. Thank you very much.
Yeah, so thank you very much. Let's all meet next month, first Tuesday again with another Cpap. Very, very interesting and common problem. So bye for now.
Thank you, Parag.
Thank you. Good night. Bye-bye. Thank you, Bharati.
Happy Dasara for everybody, and happy
Happy
Puja.
Dasara, Parag. Happy Dasara.